Okay, now you see this. Now this topic is actually on the rectus sheath, another topic. Rectus sheath means it is the sheath that has been formed by the three muscles that you have already done: external oblique, transverse abdominis, I say internal oblique, transverse abdominis. These three muscles which took origin from the different parts of your thoracic cage and the pelvic girdle, or you say hip bone, and after taking origin they inserted into the linea alba. So that means when they inserted into the linea alba means all three aponeurosis will be present in the central part of your abdomen. ये तुम लोगों ने पहले किया हुआ है. तीन मसल्स हैं जो पहले हमने किए हुए हैं, और इन तीनों मसल्स में आपने देखा था कि उसके लोअर पोर्शन में एक्सटर्नल ऑब्लिक मसल वाज हैविंग सुपरफिशियल इंग्वाइनल रिंग. जब उसको उठाया तो इंटरनल ऑब्लिक वाज हैविंग एक्चुअली फॉक्स इंग्वाइनल लोअर बॉर्डर फ्री, तो उसने भी इसमें होल दिया, एक आपको एक पैसेज प्रोवाइड किया, और इससे फिर और डीपर गए तो फिर ट्रांसवर्स एब्डोमिनस मसल था जिसने फिर एक और होल प्रोवाइड किया, और उसके बाद आ गया हमारा फेशा ट्रांसवर्सलिस जिसमें फिर एक होल है जिसका नाम है डीप इंग्वाइनल रिंग, और इसी से फिर सुपरफिशियल टू डीप इंग्वाइनल रिंग के इस पैसेज का नाम हमने इंग्वाइनल कैनाल डाला. Now but you see here, if for example you are watching here, we don't have just three muscles here, because all the muscles will take origin like the fleshy parts. When they will reach here to the linea alba, they will become aponeurotic. So linea alba will be formed by the fusion of three aponeurosis from superficial to deep on the left side, and the similar three aponeurosis from superficial to deep on the other side also. So means six aponeurosis basically they fuse together to form here relatively avascular fibrous raphe here in the middle, that is called the linea alba, that is attached here. You see, to make it more stabilized, we attach here to the tip of the xiphoid process, and down here attach here to the upper border of symphysis pubis. So these are the three aponeurosis here, but we know that. अब देखें आपने वो लीनिया एल्बा को ऐसे अगर हम छोड़ देंगे ना, तो लीनिया एल्बा भले वो 6 एपोन्यूरोसिस से मिलके भी बनी हो, तो ये ऐसे फ्लोट करेगी एक तरह से, तो उसके अपर एक्सट्रीमिटी या लोअर एक्सट्रीमिटी को फ्यूज कर दिया हमने ताकि वो थोड़ा सा मोर सपोर्टिव बन जाए. बट यू वॉच हियर, दैट सपोर्ट इज नॉट इनफ, because you see most of your anterior abdominal wall lateral to the linea alba, you can say 4-finger breadth on one side and 4-finger breadth on the other side, at least it will be just an aponeurosis, 3 aponeurosis. Aponeurosis is thin, though it is tight, okay, it is tough, but it is thin. Means if 4-finger breadth means most of your anterior abdominal wall, central part of your anterior abdominal wall is not having a flesh even, it will be having just the sheets, thin sheets. समझ गए? तो ये आप जो बीच का हिस्सा आप देख रहे हो, इसमें आपको थिन शीट्स मिलेंगी, सिर्फ एपोन्यूरोसिस ही मिलेंगे. भले आपको लीनिया एल्बा मिलती हो, लेकिन उसके बाद भी यहाँ पे एपोन्यूरोसिस ही होंगे. और ये एपोन्यूरोसिस जो है, so that means these 3 aponeurosis on this side, 3 aponeurosis on this side, almost you see should be width will be 8, you see equal to the width of the two hands, for example. So if they are just the sheaths here, aponeurosis here, and if you have a push from behind, that means push from inside here of the peritoneal fluid and the viscera, so aponeurosis will come only. What will be the support anteriorly after the viscera? 3 supports only, that is the parietal peritoneum, extraperitoneal fat, and fascia transversalis, and then immediately the aponeurosis will come. You see the aponeurosis on these 3 structures, the deeper 3 structures among the 9, and these deeper 3 structures are very delicate, so much so that even your parietal peritoneum is the simplest squamous epithelium. Thinness of all the tissues in the universe is the simplest squamous epithelium, and then you have got just the fat, and anteriorly you know that posteriorly you have a support of your vertebral column. Instead of your linea alba, posterior support is vertebral column, much thicker support you have, much stronger support you have. देखिए आप आगे की मिडलाइन और पीछे की मिडलाइन में फर्क देखिए कितना है. पीछे आपको लंबर वर्टिब्रा का पूरा पिलर है, और आगे आपके पास है उसके नाम पर लीनिया एल्बा है. 2 साइड्स पर आपको जो मसल्स पीछे मिलते हैं, वो मसल देखें और ये मसल देखें, पीछे मसल्स हैं, आगे एपोन्यूरोसिस है. तो इसका मकसद यह है कि पीछे तो आपका बल्ज नहीं होगा, विसरा आपको पीछे से दबाएंगे जरूर, लेकिन पीछे तो बल्ज नहीं होगा, आगे तो हो सकता है. इसका मकसद है कि यहां फिर नेचर ने क्या किया है इस लीनिया एल्बा में, मींस टू एक्चुअली गिव मोर रीइंफोर्समेंट टू द इंटीरियर एब्डोमिनल वॉल ऑन आइदर साइड ऑफ द मिड लाइन made by the linea alba. Nature has provided here a rectangular muscle on one side, a rectangular muscle on other side, to give the central part of the abdomen the support. Why not on the lateral? Because lateral is, we have 3 fleshy layers, external oblique flesh, that is external oblique musculature, internal oblique musculature, transverse abdominis musculature. Here we don't have problem, we have problem in the center. So in the center, nature has actually put here a pillar-like muscles here, rectangular muscles of the abdomen on the central region, one on either side. That's why that muscle is called the straight muscle of the abdomen, a rect muscle of the abdomen, rectus muscle of the abdomen. You call it rectus abdominis muscle. This is your 4th muscle, because this is your 4th muscle of the anterior abdominal wall. Basically, these were your anterior lateral abdominal wall muscles, but this was the strictly anterior abdominal wall muscle. And that muscle takes origin from where? We know already. They can take origin either from pubis, either from hip bone, or they will be inserted here into the rib cage, because we don't have any other thing, because this is a strictly anterior abdominal wall muscle. Even it cannot actually take support or attachment from even your lumbar vertebrae. Even if the lumbar vertebrae is actually giving them the lumbar fascia for attachment, it will not be available because it is too anterior. So only they have the option attachment below pubis, that's called the hip bone, and hip bone, because it is actually close to midline. So anteriorly hip bone is which bone? Which part of the bone? Pubis, not symphysis, because they will be on either side of the midline. Means midline means your pubic symphysis will be, it will be spared. समझ रहे ना, क्योंकि जब मैं इस तरीके से लगाऊंगा, एक मसल राइट का और लेफ्ट का एक ही बताएंगे आपको, जो लेफ्ट राइट का लगाएंगे तो वो मिड लाइन को छोड़ा ही हुआ होगा, जिसका मतलब पुबिक सिम्फिसिस पे उसकी अटैचमेंट नहीं होगी. उसके बेसिकली 2 हेड्स होते हैं. One head takes origin from the body of the pubis, second head takes origin from the pubic crest. आपको दिखाया था ना, pubic tubercle, and then the pubic symphysis. In between there was the crest, that is called the pubic crest. One head took origin from the anterior surface of the body of the pubis, and another head took origin from the pubic crest, and both are coming up here, and they will form single band will be created. And if a single band is created, watch this muscle, how this muscle looks like. Now see, if you are actually watching this, you see this muscle. Can you see this? This muscle, this one. This is the origin of your muscle. Taking origin from where? From the body of pubis, and another head takes origin from? Leave this blue color. I will tell you this blue color later on. But watch this here. This muscle is called the rectus abdominis. This has been cut here. We have cut here to show you this green color something else. Means it is sleeping on this green color bed sheet, you can say. We have cut here on left side to show you just the initial part of rectus abdominis muscle. This is rectus abdominis. ये समझ गए आप? ये रेक्टस एब्डोमिनस आपको अपने लेफ्ट साइड से इतना ही दिखाया गया है, काट दिया यहां से हमने. आपके कि यहां से काट दिया तो फिर यहां ऊपर नहीं है क्या? यार यू हैव कट दिस रेक्टस एब्डोमिनस ऑन दिस साइड. विल दिस बी प्रेजेंट अबव? ऑब्वियसली, बट इट्स नॉट विजिबल हियर. ओके, इट इज विजिबल ऑन अदर साइड. On other side it is there. Now this will be up to here. Further has been shown on the right side. ये देखिए, see this is now. This is here like this. Till it will reach where? Till it will reach here to the costal cartilages. Which rib in fact was giving origin, or the first rib, the highest rib that gave origin to external origin to your anterior abdominal wall muscles, and obviously the most anterior muscle you know that is called the external oblique. Which rib gave origin to the first rib, the top rib?
So the fifth rib.
Fifth rib, obviously. So that is, it is the fifth rib. Means this is now your fifth rib. You can say like this: 5, 6, 7, 8, 9, 10. This is fifth rib. So this is fifth rib. If this is fifth rib, so this should be fifth costal cartilage. This should be sixth costal cartilage. This is the seventh costal cartilage. So when you are actually bringing this muscle up here like this here, it will catch hold of the fifth costal cartilage. Not just the fifth, but down there sixth also. Not just sixth, down there seventh also. Why not eighth? Eighth is too lateral. Understand? So it will be actually inserted here. Fifth, sixth and seventh costal cartilage. So its insertion into the fifth, sixth and seventh costal cartilage. Taking origin from, we have already told you in 2 heads. One is the pubic crest, another is the body of the pubis. They join together to form a single rectangular, you say pillar-like muscle here that comes up here, and obviously it is going here little. Initially it is coming very close to midline, but later on it will leave the midline little bit, little oblique in its course. And now it will be here. So it will not be inserted here into the middle. I say it will be just sparing the xiphoid process because it has gone little lateral. Little lateral means costal cartilages will come. Which one? Not 7th first, because you are coming from below. So it will be 7th, then 6th, and then the 5th here. So it will be, but you will write it 5th, 6th, and 7th. But if you are coming from origin here, so it will be 7th, 6th, and 5th you can say. तो ये इस तरीके से इसकी ओरिजिन हो गई है और इस तरीके से इसकी इंसर्शन हो गई और बेल्ट लाइक जब इस तरीके से सपोर्ट दे देगा तो वो जो डर था हमें कि सेंट्रल पोर्शन पर एब्डामिन पे पुश बाहर आ जाएगा तो कहीं बल्ज ना आ जाए यहाँ पर, उस खतरे से हमें निजात मिल गई है। साइड से हमें कोई प्रॉब्लम नहीं है और पीछे तो वैसे ही कोई प्रॉब्लम नहीं, तो एक सपोर्ट हमें मिल गई। अगर उसके अंदर टोन होगा तो फिर आगे बल्ज होगा ही नहीं। और टोन सिर्फ नहीं मसल्स का, इसके अंदर जो फेट के लेयर्स हैं, खासतौर पे फैटी लेयर थोड़ा अंदर गए तो नहीं, मेम्ब्रेनस तो बहुत थिन सा है, वो उसका तो कोई खतरा नहीं है। पेट भरना, जो पेट, ये जो आपकी बेली फैट है, जो आपका पेट इस तरीके से बाहर फूल जाता है, ये किस वजह से होता है? ये जो फैट है सुपरफिशियल फेशाज, फैटी लेयर, और थोड़ा अंदर जाओ तो एक्स्ट्रा पेरिटोनियल फैट में भी, और इनको जब खोलोगे अंदर जाके तो एक और फैट भी पेरिटोनियल कैविटी में मिलेगी, वो भी भरी हुई होती है। ये तीनों फैट बाहर से, लेकिन सबसे ज्यादा ऑब्वियसली कैंपर्स फेशा, उसका फेट जो है ना वो सबसे बड़ी, एक समझ लो कि एक बहुत ही एक अगली लुक देगा आपको, वो जल्दी से वो फेट डेवलप हो जाता है, वो डिपॉजिट हो जाता है एक्स्ट्रा कैलोरीज। तो यहाँ पर ये चीज़ें आपको यहाँ पे मिलेंगी। अब देखें, सी नाउ इफ फॉर एग्जांपल initially when the two muscles are coming from both sides, you see left and right, initially their medial edges and their lateral edges are also there because it's rectangular, their medial edges are very close to each other and they are not running as parallel as we are expecting because they are actually moving, so their lateral edges are little diversifying. You see that this little divergence, you see that. So that means the gap between the two lateral edges of the two muscles below, I say medial edges of the muscles below, it is narrower and progressively it is getting more wider. So that means between them what is present? Linea alba is present. So the width of the linea alba below will be narrower and above will be broader. Why? Because the medial edges are getting away from each other. So your anterior abdominal wall will be weaker below or above? Above. The reason? Because above the support of, in the central region the support is less. Understand? The support is less, so you can have actually a push from the back easily here, and usually from here the hernia can take place. One of the abdominal hernias is this also, this is called the epigastric hernia. Why it is epigastric hernia is present? Epigastric, why not hypogastric? The reason, because below both sided support is actually more valid and above it is little vulnerable. The reason, because the medial edges are little away from each other. If you see, this is a linea alba, watch it, the linea alba here. You see the linea alba width here and you see the linea alba width here. Is same or narrow below and wider above? ठीक है ना? अब wider अगर above है तो इसका मकसद क्या हो गया? इसका मकसद ये हो गया कि above support कम है और यहाँ से प्रोट्रूजन ऑफ विसरा पीछे से पुश लगाएंगे तो वहाँ हर्निया के चांसेस ज्यादा हैं, क्योंकि नेचर, और इससे आपको अंदाजा हो गया. विद दिस नाउ यू विल हैव एन आइडिया that this rectus abdominis has been provided here to actually support the abdominal viscera, and where the support is less you see the abdominal viscera come out. Now if this will give you idea, if this would not have been present here, all the time you see the bulging will be outside here. Understand? And here is actually present like this here. So this is what we call here the rectus abdominis muscle here, this origin, insertion, its location. But rectus abdominis muscle is present, but we know that when the rectus abdominis is coming, already existing, already present, there are 3 aponeurosis. भाई वो तो पहले से ही 3 aponeurosis मौजूद है ना. तुम यहाँ से rectus abdominis को ऊपर लेके आए, you are bringing the rectus abdominis from the pubic bone up to the costal cartilages. There is a journey of the rectus abdominis muscle, but the rectus abdominis muscle will come across 3 aponeuroses. Now problem is whether it will be passing in front of the external oblique aponeurosis, or it will be embedded between external oblique and internal oblique, or it will be embedded between internal oblique and transverse abdominis, or it is behind the transverse abdominis, means embedded between transverse abdominis and fascia transversalis, or it will be behind the fascia transversalis. This cannot happen, because behind the fascia transversalis means it will be in the extraperitoneal fat. Muscle cannot be in the extraperitoneal fat. In the extraperitoneal fat are almost always visceral organs. So where it will be? When it will be here? Because rectus abdominis, because topic is rectus sheath, means we have to form the rectus sheath. Actually rectus sheath is the sheath or the coating of the rectus abdominis muscle provided to the rectus abdominis by the 3 aponeuroses. These are the three aponeurosis. So that indicates this rectus abdominis will be embedded between the aponeurosis of these three muscles here. Now aponeurosis of these three means where either between the external oblique and the internal oblique, or between internal and transverse abdominis. Understand? Now problem is these three aponeurosis, they are not present throughout the entire length of your rectus abdominis muscle. अब देखिए ये आपके रेक्टस एब्डोमिनस की पूरी जर्नी में तीनों एपोन्यूरोसिस इसको हमेशा अवेलेबल नहीं है. जैसे इफ यू सी हियर दिस इज कॉस्टल मार्जिन, above the costal margin there is just one aponeurosis available, external oblique, and you know that your rectus abdominis muscle is lying now on the 5th, 6th and 7th costal cartilages. You were saying that is 7, 6 and 5. Okay, same. It will be in order, it will be 3 costal cartilages, and if this is sleeping on your 3 costal cartilages, how much part of your rectus abdominis will be sleeping on it in this total entire, you say upper 1/4 for example, and its upper 1/4 when it is sleeping on costal cartilages number 5, 6 and 7, just one aponeurosis is available, and this is external oblique aponeurosis, and external oblique aponeurosis will be behind it or in front of it? In front, because the most superficial is, if it will be behind for example, then throughout the entire length of your rectus abdominis muscle should be anterior to or superficial to the external oblique. When it will be external to the external oblique, how the sheath will be created? So that means your rectus abdominis muscle will be covered by what? Covered by the colles fascia, I say by the scarpa's fascia, Camper's fascia and skin here. So that means it do not have a sheath at all. So that means it should be covered by aponeurosis of external oblique. Anteriorly it will have a sheath of external oblique up to costal margin, external oblique, but behind there is a sheath or there is nothing. There is nothing. We have 3 costal cartilages, means behind you don't have a sheath at all, because the sheath is something which has been formed by aponeurosis of one of the 3 muscles, either all of 3 or 2 of them or 1 of them. So that means anteriorly it will have a rectus sheath, means upper 1/4 of your, means above the costal margin the rectus sheath has a configuration like anteriorly it is present, posteriorly it is deficient, and posteriorly it is related to the costal cartilages, and you know that already. This is like this. See, this is related to the posteriorly costal cartilages, and if you are actually looking at this, see this is now above the costal margin. This is sleeping upon. You see this is a red color is what? This red color is rectus abdominis. Above the costal margin, sleeping on which costal cartilages? This is 5th, 6th and 7th. You see 5th, 6th and 7th. This is sleeping on it. And anteriorly what is present above it? The rectus sheath formed by external oblique aponeurosis. And this is formed by this here. So this indicates above the costal margin rectus sheath is just nothing, but it is only present anteriorly, and posteriorly rectus sheath is deficient. Though it is posteriorly sleeping just on what? Nakedly on costal cartilages 5, 6 and 7. So anteriorly, so above the costal margin the rectus sheath is just present anteriorly, and it is formed by the aponeurosis of, and these are the fibers already we have told you that they are more or less horizontally placed, you see that, then they become oblique. But below the costal margin, right from costal margin onward, how many aponeuroses will be available? Both or 3? 3, because you know that, you see sir, above was also the transverse abdominis. Transverse abdominis was above was there also, but it was from the inner aspects. If you have costal cartilages here and your rectus abdominis is sleeping like this, above is the external oblique, below was available, okay. Transverse abdominis below was available, but it was not in touch with your rectus abdominis. It was present here just under the rectus abdominis or under the thoracic cage, from the inner aspects of here, so it will not be forming the rectus sheath. But after the rectus abdominis, after your costal margin, attached to the costal margin, external oblique muscle will remain continuous throughout the entire length. This is true. But how many more muscles will join the external oblique? 2 more. One that started from the costal margin, and another which will make an appearance superficially from. अब देखें यहाँ से वो आया कहाँ से? वो आया है आपके 7वें रिब से, लेकिन अब अपीयर कहाँ से होगा? फीलिंग कहाँ से होगी उसकी? From the costal margin onward. समझ गए ना? कास्टल मार्जिन, इसका मकसद है कि दैट इंडिकेट्स दैट फ्रॉम द कास्टल मार्जिन यू हैव द एक्सटर्नल ऑब्लिक कंटिन्यूअस, टू मोर मसल्स एपोन्यूरोसिस विल बी नाउ एडिंग. So 3 aponeurosis are there. So that means next part of your rectus abdominis muscle will encounter 3 aponeurosis. Now you have to distribute the 3 aponeurosis to make now a complete sheath. Anteriorly also and posteriorly also. But who will form anterior and who will form posterior? Anteriorly will be, this is true that it will always be external oblique. Posteriorly will be and transversus abdominis. This is not true. Anteriorly will be external oblique and internal oblique. So posteriorly will be? No. Posteriorly will be internal oblique and transversus abdominis. How this will happen? How the internal oblique will be anterior and posterior both? That means it will split. You take my point? नहीं, 3 aponeurosis आ गए. एक्सटर्नल ऑब्लिक का एपोन्यूरोसिस तो आगे होगा ही, उसके बारे में तो कोई दो राय है ही नहीं. ठीक है. और ट्रांसवर्स एब्डोमिनस का मसल का एपोन्यूरोसिस वो भी पीछे होगा, इसमें भी कोई दो राय नहीं है. बीच वाला फंस गया है कि मैं क्या करूं, आगे आऊं कि पीछे जाऊं. इफ इट विल कम, फॉर एग्जांपल, इफ द internal oblique एपोन्यूरोसिस विल कम anterior to the rectus sheath, anterior to the rectus abdominis muscle, it will fuse with the aponeurosis of external oblique to make your double strength. Till the medial edge of your rectus abdominis will come, and similarly other side here they will make linea alba. So how many layers come? Two aponeurosis. But when the posterior is already present transversus abdominis muscle, actually what happens? Internal oblique muscle, when reaches here to the lateral border of your of your rectus abdominis muscle, is very important. It splits like this. Watch here. Now see this is now your muscle. Which one? Rectus abdominis. This is and this one. Understand? Now see, this is aponeurosis of internal oblique. Now as far your aponeurosis of internal oblique is concerned, your external oblique is making an aponeurosis. This will obviously go anterior to the rectus abdominis. There is no other opinion here. You see this. But when the transversus abdominis will go, it will go behind. You know this black color is fascia transversalis. This is, and last one. Understand? So this is here. So that means if for example internal oblique reaches the lateral border of your rectus abdominis muscle, this splits anterior lamina and posterior lamina. Anterior lamina has a fusion with the already existing aponeurosis of the external oblique muscle to make its the double strength, and posterior lamina will make a fusion with already existing transversus abdominis muscle to make it more stronger here till it reaches to the medial edge of your rectus abdominis, and now midline comes, and a similar pattern is from other side. They will fuse together to form now the linea alba. Understand? A linea alba will be formed here like this here. And now you can say sheath has been now, that means your rectus abdominis muscle has been totally ensheathed or not? Rectus sheath totally complete. Anteriorly also, posterior also. We have 3 layers. So anterior how many? 1.5. And posteriorly how many? 1.5. You can say like anterior lamina, posterior lamina. It has been totally ensheathed. This is your rectus sheath complete. But rectus sheath is complete means in upper 1 quarter you saw the things were different. In the middle 2 quarters, this is the problem. This is the configuration, but in the lateral 1 quarter, the configuration is different. Rectus sheath configuration below the means in the lower lateral quarter, means in the lower quarter means a quarter between, you can say between umbilicus and pubic symphysis, almost at the middle of it. So this arrangement which I was telling you is a totally ensheathed. This arrangement is from the costal margin up to, from the xiphoid process up to midway between the umbilicus and the pubic symphysis. This same thing will continue until midway between umbilicus and the pubic symphysis. The things will change. What will happen? You say that in the lower 1 quarter of the rectus sheath is different from the 2 patterns which you have seen above. What will happen here? In the lower portion, we make the posterior rectus sheath more weaker. We try to make in such a way, because in the lower portion of your rectus sheath, wants to come a blood vessel that is called the inferior epigastric artery, if you remember. If the inferior epigastric artery, so inferior epigastric artery in the lower portion of the abdomen will be lying in which layer of abdomen? Extraparator fluid, means 8th layer. If you try to come here into the rectus sheath here, so where you will come to lie anterior to the rectus sheath or posterior to the, anterior to the rectus abdominis or posterior to rectus abdominis? Posterior, because you are coming from behind. How many layers you have to cross to lie posterior to the rectus sheath, to posterior to the rectus abdominis muscle being a content of your rectus sheath? How many layers you have to cross?
It should be 3.
It should be 3. For example, number 1, fascia transversalis. Number 2, transverse abdominis muscle. Number 3, internal obliques posterior lamina. And then you will come to lie behind your rectus abdominis. Transverse abdominis and internal oblique, these are the aponeurosis which are attached to the musculature of the muscles. And if you see if for example inferior epigastric artery had passed through the aponeurosis of your 1.5 muscles, you see that is called the transverse abdominis and internal oblique, वहाँ से होता अगर तो हशर क्या होता, इधर से थोड़ी सी ना कंट्रैक्शन आ जाती, एपोन्यूरोसिस को ऐसे दबा देता. और ये न समझो कि सिर्फ आर्टरी है, इट्स नॉट जस्ट द आर्टरी बट विद द वेन आल्सो. Artery might actually suffer or can escape this kind of a compression, but how the vein can? Vein is very thin walled, means immediately the blood vessels will be blocked here. So nature has given here an advantage to the artery in such a way that the 1.5 layer means which veins? Transverse abdominis and posterior lamina of internal oblique, they will disappear from behind. Actually they will come immediately in front of the rectus abdominis muscle. Means this time you will say all 3 aponeuroses are anterior to the rectus abdominis, and posteriorly the lower 1/4 of the rectus abdominis is simply sleeping on fascia transversalis. Means you can say, so posteriorly, can you say posterior rectus sheath is formed by external by the fascia transversalis? No, you will say, sir, posteriorly rectus sheath is absent, because rectus sheath is something which has been formed from the aponeurosis of the 3 muscles. So behind, is there any aponeurosis? No. So behind there is none of the aponeurosis will be actually behind here. All 3 aponeurosis will be in front now. All 3 will be in front, means the splitting of your internal oblique and internal obliques into anterior posterior lamina is no more. Because भाई स्प्लिटिंग तब होगी जब तुम्हें आगे आधा लेयर आगे देना था, आधा लेयर पीछे देना था. जब आपका पूरा का पूरा लेयर आगे आ गया तो इसका मकसद है कि स्प्लिटिंग का खेल खत्म समझो. और जब स्प्लिटिंग का खेल खत्म तो समझ लो कि अब तीनों एपोन्यूरोसिस फ्रंट में आ गए, एंड 3 एपोन्यूरोसिस विल बी इन फ्रंट ऑफ योर लोअर 1/4 ऑफ द रेक्टस एब्डोमिनस मसल, एंड यू सी द रेक्टस एब्डोमिनस मसल हियर इन फ्रंट एंड विल रीच द मिड लाइन, एंड इन द मिड लाइन इट विल एक्चुअली मर्ज विद द लीना एल्बा. And at that time the linea alba is very narrow, you know that already. By the time you are going up here, linea alba gets more and more divarication of the rectus, and more divarication will actually make it more vulnerable for the hernia. This is due to the divarication of the rectus abdominis muscle. So that means at the 3 different levels you have 3 different configurations of the rectus sheath. Watch it here. Above first layer you have already seen here. The first means the second configuration you have seen this. But when you reach here, you see this rectus abdominis, external oblique, internal oblique, transversus abdominis. You see first, second, third. Can you see this? All 3 aponeuroses they are in front. If all 3 aponeuroses are in front, means your rectus abdominis muscle is simply sleeping on. Means these 3 configuration is one above the costal margin, another below the costal margin up to the level of midway between umbilicus and the pubic symphysis, and the third one be below that. Means in the upper 1/4 of the rectus abdominis, rectus sheath is absent posteriorly, and in the lower 1/4 of the rectus abdominis, the rectus sheath is absent posteriorly also. In the lower 1/4 it is directly sleeping upon the fascia transversalis, and the upper 1/4 it is directly sleeping on costal cartilage 5, 6, 7. But in the middle portion, you know that already it is a regular type of a rectus sheath. Uniformly you see that equally divided in 1.5 in front and 1.5 behind. But you see that because lateral margin of your rectus abdominis muscle is important in a sense that this is the area, this is the line superficially, you see that this is the landmark line, because here there was a splitting of the internal oblique. When the splitting of internal oblique takes place here, there will be a little depression, a kind of a sulcus. a kind of a sulcus will appear, and sulcus will appear only when you don't have enough fat on your abdomen. If the fat belly is not there, then this sulcus will be visible. Just the sulcus will be visible, that marks the lateral border of rectus abdominis. Understand? And that marks the lateral border of rectus abdominis, and that marks the splitting of internal oblique. And where from it starts?
Medial side of the rectus abdominis.
Medial side of rectus abdominis. From thoracic cage point of view, where from it starts? Costal margin. Because internal oblique starts from where? Costal margin, that touches here the tip of the 9th costal cartilage.
So lateral side of
Lateral side, obviously, because the lateral side will bisect what?
the
Internal
internal
oblique. This is internal oblique, so this line will stop where? Costal margin. Which point of costal margin? Incidentally, tip of 9th costal cartilage. And down it will be actually little bit curved line will be there. And where it should split, where it should stop, it will stop actually just above the inguinal ligament, you can say, in the lower portion here. This line is called the linea semilunaris. This line is called linea semilunaris. Means a semilunar line, semicircular line, semilunar. Lunar means half moon, like crescentic line. Very wide crescent. It's not like a half moon, but you see it like a crescentic line, like a rainbow line, you can see. Understand? This is called the linea semilunaris. Means upper end of the linea semilunaris will bisect which point? Will bisect actually 9th costal cartilage. And this 9th costal cartilage, this is the point where you can feel gallbladder also. And here you can feel the gallbladder. Means it is bisect, means it is touching it. And here is the costal cartilage. Means here the costal margin, tip of 9th costal cartilage, and this is the upper extremity of your linea semilunaris. And this is the point where you can superficially, or you say landmark point of view, from surface marking point of view, you can actually feel here a line and make a half circle here. This will be the fundus of gallbladder. And here you can feel the gallbladder. You know, gallbladder cannot be felt here if it is not enlarged. You ask your patient to have a full breath. You say full inspiration. Diaphragm will come down, the liver will be pressed down here. If, for example, the fundus of gallbladder can touch you, and if the fundus of the gallbladder is having an inflammation, he will immediately check the respiration, because it will touch the overlying, you say, your tip of your fingers. You say tip of your fingers, it will touch here. अब देखें ना, आप सांस लेंगे, डायफ्राम नीचे आएगा, लिवर नीचे आएगा, और गॉल ब्लैडर अगर इन्फ्लेम्ड है तो एकदम से आपके फिंगर्स को टच करेगा, और जैसे फिंगर्स को टच करेगा, as soon as you actually your fingers will touch the gall bladder here, immediately the patient will check his respiration. Means the sign is positive. This is indicates acute cholecystitis, and this sign is called the Murphy's sign. For this purpose, I am actually giving you Murphy's sign. Why here? The reason is that because you are discussing here is linea semilunaris. And linea semilunaris, actually it's a surface marking you should know here. What it is, why it is formed, where it will be, how it actually is related to the gallbladder fundus, which costal cartilage, how the Murphy's sign is elicited there, etc. Now, this is something you have seen. Now, for example, consider if you are putting your hand behind the rectus abdominis muscle, will there be any obstruction? For example, if you are, this is rectus abdominis and you are putting your hand behind it, will there be any obstruction? Or is it just sleeping? See, if you are sleeping over some bed, for example, if I am putting hand under you, under your body, will there be anything which obstruct me? Nothing. Which one? Okay, even if it splits, internal oblique splitting is like this, and the rectus abdominis, you see, this is rectus abdominis. If I am putting my, splitting is here and here. If I am putting my hand here in the rectus abdominis muscle under that, will anything obstruct me? Nothing. If I am putting my hand here in front of the rectus abdominis muscle, will anything obstruct me? Will anything? No. Actually, anteriorly you will be obstructed, posteriorly not. That's why inferior epigastric artery, when it enters, nothing obstructed in it. Easily it can go, and from above, you know that from internal thoracic artery is one of the terminal branches that enter here between the costal and the external slips of diaphragm. And here the artery actually enters one of the terminal branches. One goes above the dome of the diaphragm, that's called the musculophrenic, and one enters here between the two slips, that is external and the costal slips, and enters into your rectus sheath. Behind the rectus abdominis muscle, being a content of rectus sheath. This is called superior epigastric artery. From below inferior epigastric, from above superior epigastric. They are anastomosed with each other. And similarly the veins. Inferior epigastric vein, that will drain into external iliac, and external iliac is actually joins with the internal iliac to form the common iliac. So this will be a tributary of indirectly of the inferior vena cava. But superior epigastric is the indirectly the tributary of Superior vena cava, because it is internal thoracic. Internal thoracic is the tributary of subclavian. Subclavian joins with the internal jugular vein to form the brachiocephalic. Two brachiocephalics join together to form superior vena cava. Means superior epigastric artery and inferior epigastric, superior epigastric vein and the inferior epigastric vein. Their anastomosis indirectly is the anastomosis between superior and the inferior vena cava. So if there is obstruction in the superior vena cava, collateral will be provided here through the inferior. If there is a blockade here in the inferior, there is a this collateral between through the superior into the superior vena cava. So this is a very important collateral arrangement between the superior and inferior vena cava through this rectus abdominis muscle, through this rectus sheath here, through these two veins also. तो इन veins की भी एक collateral importance बहुत है. सिलसिला तो ठीक है यहाँ पर. अगर ये anteriorly भी ऐसा ही होता, if for example anteriorly there is no any obstruction, for example, so anteriorly would have been what? External oblique aponeurosis and the internal oblique anterior lamina. So for example, if there is no obstruction anteriorly, and if you will flex, for example, bend your trunk, there will be a folding of the, because if this would have been straight now, for example, and you are bending here, this will fold or not? See how. See now. If this is here, behind you don't have any pump, but if this is here, and now you are bending, the anterior will be folded, because anterior you don't have a support, you have just support of the skin, etc. like here, so it will be folded here. You say, sir, posteriorly will be folded. No, posteriorly there is a support of your rectus abdominis muscle, so posteriorly it will not be folded. Anteriorly it will be folded, and posteriorly we can't afford any obstruction because you have to actually facilitate the passage of the vessels. तो anteriorly आपको ये fold मिलेगा. तो इस fold को avoid करने के लिए नेचर ने एक arrangement दिया हुआ है. Which arrangement? See. Anterior rectus sheath, anteriorly, not above the costal margin, below the costal margin, at the level of the xiphoid process. What will happen if this is rectus abdominis, my hand is rectus abdominis muscle, this is my anterior sheath. In the anterior sheath, I will actually put something here deeper so that some part of the fibrous aponeurosis of the anterior rectus sheath will penetrate into the musculature of the rectus abdominis. Like this. Like this. Penetrating the rectus abdominis, but hardly 2% of depth of the rectus abdominis, not throughout up to the posterior. If up to the posterior, then it will catch hold of your posterior sheath also, there will be obstruction there as well. Only how much of the thickness of your rectus abdominis? Just 2 to 3%, so that it should be firmly anchored into it and you cannot remove this. This will be musculature or fibrous? Tendinous. This is a, when you remove this, can it be easily removed? No, you have to cut it. So you will feel here intersection or not? Musculature or tendinous? Tendinous intersection. That is called the tendinous intersection. This is actually giving one at the time. You see that when there is a, you see one just below the, you can say just at the below, you say this below the xiphoid process, you see this tendinous intersection. Then another will be actually at the level of umbilicus, and third is midway between both of them. 3 tendinous intersection, they are very important. Sometimes even the fourth can be down there also, but rarely it is present. But these 3 are constant. One is at the level of umbilicus, another is the level of, another is at the level of just below the xiphoid process, and third will be between them. These are called the tendinous intersections. Means if this will be the tendinous intersection like this, like for example, like here, so your rectus sheath will be actually in 3 compartments or not? It will be in 3 compartments. And now when you are actually folding here, will it be just a single unit or divided into 3 units now? So folding will not be actually more prominent. And folding is not prominent, and you are making exercise and your muscles become hypertrophied. So rectus abdominis will look like a single belt or in 3 pieces. 3 or 6. This is called 6 packs. Understand? So this abdomen is called the 6 packs. So 6 packs is basically the rectus abdominis in 3 pieces because of three intersections here. These are called the three tendinous intersections by what? By the anterior rectus sheath from the anterior side. How much? Only you can say ceiling up to even 2% depth of your thickness of your rectus abdominis muscle. So this is something that you are actually watching here. Now see, in this especially when you are actually watching these three and you are coming to this. This is now your external oblique. And external oblique muscle we have removed here, and now you are watching here. This is internal oblique muscle, and your internal oblique muscle. See, when I am actually cutting this here totally this will be what? This is rectus abdominis. When I am lifting the rectus abdominis from here. Okay, if this is now your rectus abdominis muscle, what I have removed here to show you this red color rectus abdominis muscle, anterior rectus sheath. What I have removed here? I have removed the external oblique aponeurosis and anterior lamina of internal oblique also. That's why I am actually here. When you have removed the external oblique and internal oblique, both lamina, say anterior lamina and internal oblique, anterior rectus sheath full, will this be totally removed, or intersections parts will there be? Fibrous portions or fibrous intersections will stay there because they have penetrated into the depth of the muscle, in some 2 to 3% of depth of the muscle. That's why they are visible here. This will make actually 1, 2, 3 pieces there. 6 packs is due to this name. If for example you are watching in these areas, when you come on the other side, because from other side I have removed the entirely rectus abdominis muscle. So what I am actually showing you here, posterior rectus sheath. If I am touching this, exactly what this will be, transverse abdominis or posterior lamina of internal oblique, because this will be more superficial, posterior lamina of internal oblique. Now if for example you are watching the posterior lamina of internal oblique, see now this line, below I am making here dots. What these dots represent? Fascia transversalis. Fascia transversalis. You see, sir, ये posterior rectus sheath which is coming from below up to here, ये जो posterior rectus sheath है जिसमें अभी internal oblique है, तो इसके पीछे यकीनन transverse abdominis भी होगा. इसको समझना एक बहुत इंपॉर्टेंट यहाँ लैंडमार्क आ रहा है. See for example, you have here external oblique, you have this one internal oblique, fascia transversalis, black shirt is, sorry, this is transverse abdominis, black shirt is fascia transversalis. If for example it is here, this splits, goes behind, and this splits, you see, comes in front. This joins with the external oblique aponeurosis to form anterior rectus sheath, and this will form posterior rectus sheath. It will forming here on its medial edge, it will form linea alba. But lower down, where? In the lower 1/4 of the rectus abdominis. This I am removing, okay. These two, they will come, stay behind or come in front. This is continuous. How they can come in front? Means in the lower 1/4 of your rectus abdominis muscle, the posterior part of the rectus sheath should detach from the rest of the posterior rectus sheath. Detach होगा कि नहीं होगा? So it should detach it. How it will detach? It will break it from, like all three aponeuroses in front or not? Rectus abdominis directly lying upon what? When I am actually removing this rectus abdominis muscle, this line is demarcates the detachment of the lower part of the rectus sheath from behind, yes or no? So line will be created. This arch-like line that marks the end of a lower extremity of posterior rectus sheath, and this marks the change of the rectus sheath configuration. What has come left behind and come in front? The posterior lamina of internal oblique and the transverse abdominis, both they have come in front. So a line will be created that marks immediately kind of you say the free edge is there. And free edge, will this be visible, or when you are lifting the rectus abdominis then it will show? So see this. Rectus abdominis muscle has been cut here to show you this arch-like line or not. This line is called the arcuate line. You see linea arcuatus, linea alba, linea semilunaris. These are the lines actually. Linea means line. So this is called linea. This is called what? Arcuate line. So arcuate line demarcates what? Arcuate line demarcates the point or the area or the line, arch-like line, which is concavity is below. Sometimes it is arch also. So concavity is below. It's arch-like. It's like an arch. It's not having concavity above. Its concavity is below because it's being pulled from above. You see that you will not say concavity below or above. You can think here that it will be actually pulled from below or above. Below it is not present. Something is not present below. It's above. So it is pulling above. Like here, so concavity will be below, is directed below because you are being pulled above. You see, this is logic is there. So if for example like here, so below that line, rectus abdominis is totally sleeping on what? Fascia transversalis this here, and when you are putting your finger here over the fascia transversalis and pressing here, underneath will be extraperitoneal fat, and you know that underneath will be the blood vessels. And you know that laterally will be your external iliac artery, which is about to become femoral, and just before becoming femoral it is giving here a branch. His name is the inferior epigastric artery, and inferior epigastric artery will be running here, and because it is running like this here and it is coming here, when it will be running here like this, it will be easily coming onto your behind the lower part of your rectus abdominis muscle, which is now separated only by fascia transversalis. Otherwise it would have been separated by two aponeurosis. This would have been very difficult for your inferior epigastric artery to come into the rectus sheath. तो अब क्या होगा? बड़े आराम से आ जाएगी. तो कहाँ इसको आने का रास्ता क्या, जगह क्या है? आर्क्यूट लाइन से ऊपर क्या आर्क्यूट लाइन से नीचे? बिलो ज़ाहिर है, क्योंकि आर्क्यूट लाइन से अगर ऊपर आएगी तो एपोन्यूरोसिस क्रॉस करेगी, तो फिर नीचे के दो एपोन्यूरोसिस को आगे जाने की जरूरत ही क्या थी जब ये हो सकता है. तो इसको यहाँ पर फ्री पैसेज दिया गया है. ये जो दो गई है ना आगे, ये इसी वजह से गई, वरना ये नहीं आ सकती थी यहाँ पे. Because why the nature has actually caused the posterior rectus sheath deficient here to bring this aponeurosis in front to make the easy access of passage of this inferior epigastric artery like. So if for example like this was your rectus abdominis, and here from was coming your inferior epigastric. So you see inferior epigastric disappears here from or disappears behind the rectus abdominis. So that means where lateral edge of your you can say, if it's going like this, you see this here, if it's going like this, here's the lateral edge of your rectus abdominis, and this is now your artery. This is called inferior epigastric, this is lateral edge, and below it was inguinal ligament, so triangle was created. This was the triangle that is called the inguinal triangle, and this triangle is called the triangle of Hazelbach also. And deep to the inguinal, deep to this fascia transversalis, you know that in the fascia transversalis there was deep inguinal ring also, and when it was running here, when it was running like this, it was touching the medial edge of deep inguinal ring like this. So when this was formed, inguinal triangle was formed, deep inguinal ring should stay outside, lateral to that. And here, so that means that this will be forming the floor of your inguinal canal. Means if there is a bump here, it is a direct inguinal hernia. And indirect inguinal hernia, it was emerging from the deep inguinal ring because already there was open processus vaginalis. That was indirect inguinal hernia, and that is almost always associated with hydrocele, because when the obliterated the processus vaginalis not obliterated, fluid can come in the tunica vaginalis. Scrotal swelling will also be there. So this is something that you are actually watching in this area. Now if for example you are watching in this, understand, so if you are looking at this now, see the layers. The first layer you know that is called the skin. Next this green color is called the fatty layer. Next this blue color is membranous. Now in the midline we are taking, so this will be no, this is the you can say okay, yes, you are right, this is called external oblique. So entirely external oblique aponeurosis is available. But when you are actually coming down here, if you see that it's not just external oblique, when you are coming here behind, you see that we have got behind what? Internal. This is transversus abdominis. On the back side, if you are actually cutting here in such a way, if the rectus abdominis has been cut here, anteriorly we have got the rectus abdominis muscle, let's say external oblique present anterior to rectus abdominis. If this is present here, it's not just present here, but behind we have got this transversus abdominis, and this will be internal oblique, and this is transversus abdominis. Behind we have two layers, okay. But below this line, these two layers have come in front also or not? So this will be all three layers. And above this you see that only one external oblique is there. But in between you know that is present not just external oblique but will be present internal obliques, anterior lamina also. But this is present where? This is present just below the costal margin, not above that. So here 2 means 1.5. But below will be all three, so behind it will be vacant. So vacant means it is lying on what? You see the blue color is lying just on fascia transversal and behind will be here. And this is the time very easily below the arcuate line, this inferior epigastric artery can enter. And because in front we have intersections, in front nothing can be passed, but behind very easily can come. And from above it is coming here now your superior epigastric artery. And below it is coming your inferior epigastric artery. This is what we call the rectus sheath, and this is now the rectus abdominis muscle here. Now, this posterior rectus sheath is weak at which point?
The posterior.
Posterior rectus sheath is having a strength uniform from above downward, or it is weaker at some point?
Weaker
Below the arcuate line. So below the arcuate line it is weaker, so there are chances that if from push is from behind, the protrusion of the viscera can easily take place. Yes or no? So below that it can push like here. Means below the arcuate line it can push. But we know that we have a support of the rectus abdominis muscle, all with the three aponeurosis, okay, but because behind you don't have a support, so it can hit. This kind of a hernia is called Spegelian hernia also. This is called the Spegelian hernia. Spegelian hernia is a hernia or a protrusion of the viscera below the arcuate line from the posterior part of the rectus sheath here. Below this here, posterior rectus sheath is not present, but you say below that. It can push here because the lower part of your rectus abdominis muscle is there, so it will not push the rectus abdominis, but it will pass from sides of the rectus abdominis, from its lateral border, making here a bump here in the lower part of the abdomen here. You get my point? Because below you know that below rectus abdominis, below even the splitting is not there. All are coming in front, so very easily the lateral part will give you the passage. Lateral border of the rectus abdominis, lateral border आपका rectus abdominis का इस जगह पर ऊपर जब दो लेमिना में तकसीम हो रहा था ऐसे तो ये इस जगह पर पीछे से भी सपोर्ट है तो हर्निया नहीं हो सकती, और यहां से अगर हो भी गई तो क्या लेटरल साइड से इस लेटरल मार्जिन क्या इसको पैसेज देगा क्या? यहां भाई आप देखिए यहां से ये लेटरल मार्जिन है, लेटरल मार्जिन पे आपका इंटरनल ऑब्लिक दो में स्प्लिट हुआ था ना, ऐसे जब स्प्लिट होगा तो पोस्टीरियर से देखो कुछ नहीं आएगा, अगर आ भी गया तो इस जगह से आगे से हर्निया डेवलप नहीं हो सकेगी। लेकिन जब ये सारे इधर आ गए और यहां से ये पुश भी आसान हो गया तो ये लेटरल बॉर्डर जो है वो उसको आसानी से इस तरीके से पैसेज दे देगा और तीन ओपन से उठ के खड़े हो जाएंगे और यहां पंप आ जाएगा आपका, और ये है स्पेगेलियन हर्निया कहते हैं। स्पेगेलियन हर्निया स्टार्ट्स फ्रॉम वेयर? स्टार्ट्स फ्रॉम द पोस्टीरियर रेक्टस शीथ बिलो द आर्किएट लाइन and emerges from the lateral border of your lower part of the rectus abdominis muscle to make here a bump in the lower lateral part of the abdomen. This is called the Spegelian hernia, and this is possible only to understand when you have got the basics of the rectus sheath. With these three lines, rectus abdominis muscle, now see, if for example rectus sheath contents will be inferior and superior epigastric artery and vein, rectus abdominis itself, lower part of the rectus abdominis, sometimes it is supported here by another muscle. It's not present in all people, but you see that is supported by this blue color muscle. This is only in the lower 1/4, you see, less than 1/4. Taking origin from the body of the pubis or the pubic crest, immediately actually merges with the midline, with the other side here. So kind of a pyramid will be created. This is called the pyramidalis muscle. This is not present in all people. We said this is called very thin pyramidalis muscle to give support to the lower part of the rectus abdominis muscle. This is pyramidalis, one of the contents of anterior to the rectus abdominis, not from posterior. Posteriorly we have just fascia transversalis. Understand? And posteriorly how you can afford giving pyramidalis muscle behind, because you have to have entrance of your inferior epigastric artery. For this purpose you have actually got your two aponeurosis split from its original aponeurosis to come in front. वहाँ से तो आपने अरेंजमेंट की है इतनी, और आप फिर वहाँ उनको अरेंज करके वो मसल डाल दोगे वहाँ पर, एपोन्यूरोसिस अभी भी जान छुड़ाई है, तो वो आप आगे देंगे ताकि उसको आप आगे से सपोर्ट मिल सके, तो उसका नाम होता है पैरामेडिलिस, इट्स वन ऑफ द कंटेंट्स। और इसके अलावा इंटरकास्टल जो नर्व्स में आपको आगे चल के बताऊंगा, तो दिस विल आल्सो बी, आपको थोड़ा सा याद होगा मेरा ख्याल है, अगर आप थोड़ा सा देखिए इंटरकास्टल जो आपकी मसल्स थी उनमें 3 लेयर्स के जो 3 मसल्स थे आपके, उनमें से 2 लेयर्स के बीच में होते थे न्यूरोवास्कुलर बंडल्स, इंटरनल इंटरकास्टल एंड इनरमोस्ट इंटरकास्टल। Similar thing is here because it is just same arrangement. So your muscles actually, your neurovascular bundles should be present between anterior, say between external and internal, or between internal and transverse. Understand? So between internal and transverse up to here. But when it reaches up to here, internal splits into 2. Understand? So it is like this. This is between here. These two are internal. This is external and this is transverse abdominis. Here is your neurovascular bundles. When they reach the lateral border of your rectus abdominis, here internal splits into 2 laminae, anterior lamina and posterior lamina, where the neurovascular bundles will be trapped in the anterior rectus sheath or in the posterior rectus sheath. Posterior rectus sheath, because it will be here. Yes, it will be here. So they are in the posterior rectus sheath. But when they run in the posterior rectus sheath, they will be behind the rectus abdominis or not? But they will not remain behind the rectus abdominis, because they will now penetrate the posterior lamina of internal oblique to become a content of the rectus sheath. Lying behind what? Behind the rectus abdominis. They will penetrate the rectus abdominis, because it is nerve, it has to supply the muscle also. And after penetrating, what they will do? They will penetrate the anterior rectus sheath also to come under the skin to become cutaneous. Intercostals are coming like this. So if the intercostals are coming from the posterior rectus sheath to the anterior side here, will they be a content of rectus sheath also or not? Lower 6 intercostals, they are the contents of rectus sheath. So rectus sheath contents will be the lower 6 intercostal neurovascular bundles. And how they are coming, you should actually be traveling. Like for example, if this is present here, you see your intercostals will be present here. And if they are present, so they will be trapped here. And they are coming, passing through this, and now, and they will be here. Understand? So they will be a content of this. So now rectus sheath contents will be rectus abdominis itself, paramedulis, behind will be the inferior epigastric artery and veins, superior epigastric artery and vein, then anastomosis, and lower 6 intercostal neurovascular bundles will also be there. Understand? So this will be actually present here, and throughout the entire length you see that all lower 6 intercostal nerves will supply the different levels of your rectus abdominis muscle. But who will supply the paramedulis? Obviously lowest one. The 12th will supply only the paramedulis. And who will supply your remaining 3? All these 6 plus L1 also.
So अगर paramedulis के यहाँ पे ना हो जाए,
it will supply the rectus abdominis lower portion. But who will supply the remaining already existing 3 muscles? All 6 plus 1 more, and 1 more will be the L1. Above the, because you see above the inguinal ligament, this is the range of L1. So L1 will also supply, but the L1 will never supply rectus abdominis. Okay, L1 never enters into the rectus abdominis muscle. That will be actually the, so this is the rectus sheath. This you should actually be doing their MCQs and everything which is present in your notes and all these things. And Spegelian hernia, what it is and its concept, you should actually be doing this also. So read this tonight and complete it along with this video here. Inshallah, this video will be uploaded soon.
Sir, the arcuate line, it starts from the mid of the...
So between umbilicus and you can say pubic symphysis, midway between there. Rectus is बड़ा important topic है, ये बहुत आता है. ये inguinal canal, spermatic cord, ये सारी चीज़ें जो है ना ये बहुत घूम फिर के आती हैं. लेकिन ये तब होगा जब स्ट्रक्चर ऑफ एब्डोमिनल वॉल का पता होगा और तीनों मसल्स को अच्छे तरीके से ओरिजिन इंसर्शन हो, उनकी रेमिफिकेशन ये कर दे लेंगे ना आप, तो फिर उसके बाद इसमें कोई मसला ही नहीं है. कोई असल चीज़ है कि कंसेप्ट आ जाएगा.